You're welcome, Jane. Alexandra, you asked, what expires at 8 p.m.? This link, so this offering for this $97 for our CEs for our webinar today, it expires this price at 8 p.m. Eastern Standard Time. Annette, you access the ethics piece by logging into ecarebehavioralinstitute.com, going up into the upper right-hand corner of your dashboard, and then you will find it there. Marcy Morris, if I have paid for the CEUs previously, will the 2 bonus items be included? Yes. All of these are included in the pre-webinar rate as well. Norma, if you paid for the CEs and did not get an email, how do you know if your attendance is being counted towards the CEs? All right, so Norma, I'm going to have Nika take care of that because that is you're verifying on your end. So I'm going to skip over your question. Mary Kellum, is there going to be an email giving directions on CE and evaluation and time frame? There will be an email that gives you a certificate for your CEs, Mary. And the time frame is just 24 hours, so you'll get it tomorrow morning. Okay, you'll get it by tomorrow morning. Tay Robson, I'm unable to locate the link to complete the form for attendance. So Tay, that link is for non-paying members. So if you're a non-paying member and you are looking for a certificate of attendance, then you can access that form. It says right in the chat, certificate of completion request, non-paying attendees. So not in the Q&A, go over to the chat, and it's the link that says certificate of completion request. Now, if you are a paying member, your attendance is monitored as soon as you log into Zoom. So I hope that answered either one of those. I hope that answered your question. Marcy, thank you, Dan. Please verify. Okay, so Nika will take care of Marcy. There is no exam for today's webinar. Kimberly Melendez, if you're looking for the CEU certificate and you paid, then you will be emailed that tomorrow morning. Please check your email inbox, your junk, or your spam. If you are a non-paying member and you're looking for a certificate of attendance, please head over to the chat. It says certificate of completion request, non-paying attendees, and just click that link right below it. Please make sure you fill it out prior to 9 a.m. tomorrow. Priscilla Hurd, yes, unlimited members do get CEUs for our live webinars. Not certification programs, but our live webinars, yes, you do. All right, why are they asking for CC for certificate? Angela, some people would like either their CEUs, which again, that's what we're offering for $97. So if you are in the field and you're looking to have CEs for today, we're offering those and we've put the link in the chat. Others are not looking to upgrade for CEs, but would just like a certificate of attendance. So we're giving those 2 options as people are asking for them. All right, 1 more minute to answer as many questions as I can. Elizabeth, does the full membership give access to recording of this presentation? Yes, if you purchase the unlimited membership, you get access to all of our live webinar recordings and trainings. All right, just not the certifications. Certifications you do have to pay for. Camila, can we have the email or link for us to apply to the certification? I will send that to you. The certification, I think you mean, Camila, I think you mean the certificate of attendance. I'm gonna scroll down and see. Let me type that up. All right, it is 11:46. So Nika and I are gonna continue answering any eCare related questions throughout the next few minutes. So we'll be taking care of you all. I'm gonna stop my share so it goes back to Christina's slides, and Christina, you can go ahead and pick up wherever you left off.
Okay, well, welcome back from that very fast 15-minute break, right? I wanted to point out a couple of things in regard to resources that you have that I provided. Um, on page 9 of your course pack, um, glasses come. Um, there is additional information about the different types of traumatic loss, well, the expansion of the types of traumatic loss that we talked about earlier today, if you want that in a different written format. But it also considers the clinical considerations and clinical integration. So my suggestion would be to check that out. Somebody had asked about the differential diagnosis between trauma and grief. You can find that on page 20 in your course pack. Right now, we're getting ready to talk about familial and multicultural variables. In your course pack between pages 20 and 24, you can find additional information to support what we're talking about today, because all the hours, right? And boy, I'll tell you what, I just listening to all the questions about, what you get with your, um, what, if you are able to take a look at the recording of this, and if you join eCare, I had no idea. I'm finding that very fascinating. So that's spectacular. Great news. Okay. So I've been bringing this up, cannot talk about culture unless we're talking about family and grief, right? So there are many influences that we have to take into consideration when we're talking about familial and cultural influences. This includes, number one, cultural and beliefs and values. What do we have expectations about? What are the spiritual religious expectations within that culture? And if you're in an individualistic culture versus a collective culture. So in an individualistic culture, grief tends to be more of an event that is not owned by the community the same way you see in collectivistic cultures. Grief expressions and rituals are also another form of consideration when looking at culture and families. So, what is a norm? I just gave you lots of examples about that in regard to, like, for example, the woman who lost her husband to suicide. What are the traditions? Some cultures have traditions where for a year, if the wife is a widow, she wears black for the entire year. Or maybe there is for example, some cultures where the role of the adult male child, if there is one, is to take on certain responsibilities for that year. And at that year mark, that's when those responsibilities then have shifted. So you have to take those into consideration as well and understand them. You're not going to understand all this stuff. I don't even understand all this stuff, meaning all the norms and whatnot. A really good resource for that. And no, I do not know the author. You're not expected to buy this, but there is a book called How to Be a Perfect Stranger. And boy, is it a nice boiled down. I've got it right behind me. You can't see it because you've got my background here. Because those are not my books. But like I said, that would be a good resource for you there. And then what's considered stigma and disenfranchised grief in that culture. Even though you may think it's disenfranchised, that may not be a disenfranchised grief in their culture. The family roles and relationships, which I've just addressed there, attachment patterns within the relationships. For example, if somebody, let's say that there was a tragic accident, a very traumatic accident, and that person is from a culture where the person who is harmed uh, is not really the person that has the role in the family of making medical decisions, but rather that's taken over by the family. That doesn't mean that it's wrong. It just means it's a cultural norm. And I remember I've done some presentations to groups of doctors, medical doctors, and they have no, unfortunately, are not exposed to how to navigate different familial dynamics such as that, where the person who is the patient would be the one that's making medical decisions versus, or opposite. So that we have to take that into our thinking there. And then what are the responses of the surviving members? And we have given you multiple examples of that today. We want to also look at what is the familial support and adaptation. So, for example, there was a presentation I did on adult surviving siblings. I don't know how many of you have lost a sibling. It's an extremely disenfranchised group of individuals. And I see, we have the thumbs up, and it's kind of like you want a thumbs down at the same time, right? The person that we've lost. We had an expectation, perhaps, of what our roles were going to be later on. Was there going to be instrumental support, meaning doing things for each other? Was there going to be a being able to share the familial history like no one else possibly can? I might have known you or you know me my entire life, other than our parents. There might be financial support. Who's the holder of the rituals in the family? We might have been close as the younger children, and then life came and we kind of pulled away from each other as careers came in and families came in. And then, our parents pass away. We're kind of like this next generation. And as siblings, we begin to get closer to one another. Who's taking on responsibilities for our aging parents? So again, this familial support and adaptation is very culturally bound, but it's familial bound as well. So, what is how does the family cope? Is the family like completely closed in their communication style? Well, how's that working out? My husband's family has he's going to kill me for this. He won't watch us. Anyway, his family is very closed in their communication. His aunt just died last week. Loved his aunt. And I said, well, how did she die? Because nobody even said anything about the fact that she was like in the hospital. He said, I don't know. I'm like, how do you not know? You're married to a psychologist who wants to know all the things. Like, how do you not know? Well, nobody told me anything. I'm like, okay. Well, is it okay if I call your dad? That was his sister. He's like, yeah, that's fine. I had him on speaker and we're talking, and I can hear him. He's crushed. I can hear him crushed. And I said, my God, Dale, how did how did she pass? And he goes, I think she had cancer. Now, mind you, they spend a lot of time together, like even as adults. Well, what kind of cancer? Well, I'm not sure. And it's so different. Like, then in my family, everybody knew everything, maybe all too much sometimes. And I looked at him after I had the conversation and I said, Jeff, this isn't about people not telling you. This is about your family not telling each other. And it's getting in the way right now. But I couldn't look at him and be like, see, your family's all blah, 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 because no, that's their family. That is the familial influence on their lives and in their grief. I know that, hey, look, we all have our things. And what are their ability to share stories and memories? Then we have identity, meaning, and a sense of legacy. When we are in family, we have shared narratives. You can tell me stories about your family around the holidays. You can tell me stories about like when a sibling was born. You can tell me what the identity was of your family within the culture itself and in your community. What is allowed in regard to continued bonds in your culture? And is there intergenerational transmission of grief, beliefs, and coping styles? And there is intergenerational trauma that is passed down. That is covered extensively in your course handbook because we don't have enough. That could be its own presentation as well. Intergenerational trauma. And when we're talking about traumatic grief, you have to talk about intergenerational trauma. Many theories on intergenerational trauma, including an integrated and I have like one slide that talks about it, but it's really expanded in your course handbook. And then access to resources. Well, as we know, different socioeconomic factors. I mean, do you even have access to healthcare? Do you have access to community resources to help rebuild? What if your home burnt down? Is there a resource there to help you get back on your feet? Can the Red Cross step in? Would they step in? Is there a societal support network to provide you what you need in these times of loss? And what are those? What are their attitudes towards professional support? Some cultures want to have nothing to do with you at all. There is a stigma associated with a mental health profession. Or they have expectations that you're going to wear the white coat, right? You are the expert. And then there's other cultures where being in that white coat does not work. There's a lot of mistrust due to cultural imbalances. So what are their clinical considerations when we're talking about this? Well, I can't give you any hard definition of what is considered quote unquote normal grief. Look at all of the mediators, and there's so many other mediators, but there's no single definition of that. I can give you a general definition like we started out today. Those practices are different across different cultures. You should be sensitive to that and become more sensitive to it. It shapes how we grieve and how we cope. And you're going to assess that not only during your intake, but also throughout the grieving, your work with that client. You got to look at those influences as well. And we talked about restoration versus loss orientation. So now I'm even more thankful for that question that was asked from that individual about understanding what kind of grieving does that person, how do we know a grieving style? And then therefore, how do we talk about coping? So you got to recognize the differences between those. And then again, please take a look at your own cultural humility. Ask yourself those questions that you just had in those like last two slides. What about you? What's your self-awareness? So that if you do bring it into the room, you don't shy away from things that are confusing, or you don't lean into things that are familiar, therefore stunting or focusing your interventions more in line with your expectations as opposed to that which is uncomfortable to learn how to navigate. Now, religion and spirituality. I'm going to make it real quick of these definitions, okay? Religion is obviously a group of individuals who adhere to an institutionalized pattern of beliefs, behaviors, and experiences that are oriented towards spiritual concerns by a shared community and transmitted from generation to generation. There's beautiful support. There can be a community to which you can turn in times of need, although there is something called complicated spiritual grief. I might be able to attend to that when we come to assessment. But you have a community that passes down these opportunities for people to turn towards you. And I know during COVID, for example, I worked with several clients, obviously telehealth, who had a religious community to whom they've been able to turn in this time of need. Spirituality is different. This is our need in order to connect to that which is bigger than ourselves, that which is unknowable, the numinous, that which is unknowable. How do I connect to that which is bigger than yourself? I don't care if it's a rock. That's not even the point. The point is, how do you connect to something bigger? If you're atheist, okay, fine. If you're agnostic, fine. That's not my point. How do you find meaning? How do you find purpose? Is there a connection to that which is a bigger reason for what you've got going on here? If the reason for being on earth is to transmit from from one generation to the next, why is that important? What is the importance of that? What makes it important? How does that constitute importance? We do know that people who have religious and or spiritual beliefs do tend to fare better through coping with trauma and with coping with grief. But that doesn't mean people who do not have that cannot cope. It's a form of a coping skill, and it provides a lot of clinical considerations. It shapes their grief responses. Somebody who is Jewish may have different expectations in their grieving process than somebody who is Catholic versus somebody who's Muslim. Do you see what I'm saying? There are going to be different expectations about the rituals. After the loss in the Jewish community, there's a 7 day of sitting Shiva where your community comes in and takes care of it. It's beautiful. community comes in and takes care of you, you are meant to grieve, and your community is there to support you. We have certain cultures where there's tons of rituals and other cultures where there's not a whole lot. Those faith communities can provide the support, as I've mentioned. And loss can, a lot of people talk about how people can feel more angry to God, towards God or one's higher power when there's been a death. But sometimes people lean into their belief system further. They develop a closer relationship. When there is a violation in a traumatic grief, that can prove difficult because some people it takes a little bit of time to potentially get to a place where, oh, there's a reason for everything. You know, trying to make sense of it from this benign perspective. There's a reason for anything. Because going into the grieving process of there's a reason for everything kind of thing is being overwhelmed by the trauma and the intrusion of those memories. So getting to that place can be supported by one's religious and or spiritual belief systems. It can facilitate meaning making and facilitate coping. And then those needs may change over time. I've had some clients, I have one in particular that has leaned into her spiritual community very much after the loss of her child to a violent accident, a very violent accident. And originally she leaned into her community, but then the community began to fracture a little bit, not real happy. Some people were there to support her, but part of her religious community was rejecting of the way that she was grieving and began to pull away from her, so that she had this selective sharing that was going on. So much so, she got so pained by this that she said, I think I want to go check out other other religions. And I will support her through that, whatever you need to do. That doesn't mean she won't circle back. It doesn't mean we won't talk about what it's like to be in those communities and what might she, how does she want to reconcile that, or does she want to communicate around, her concerns? But I'm going to support my clients. I'm following her lead. She knows better about her than I will ever know about her. If this is her path, my job is to facilitate and walk next to her during that path. It's idiosyncratic. Everybody's grief and everybody's trauma is completely idiosyncratic. Oh, I brought it in further. Sooner. Complicated spiritual grief. How many of you have heard about complicated spiritual grief? Like an actual, like there is an evaluation and an evaluation measure for complicated spiritual grief. Anyone? 10, 11, 12. Okay, good. I see a good amount of hands up. But now you're all going to be able to do it. So that makes me even happier. Okay. Complicated spiritual grief. I'm not just talking about that when spirituality becomes complicated. There's actually some research done by Laurie Burke and Robert Niemeyer and other colleagues on what constitutes what complicated spiritual grief is. If you look in your course pack, I have provided you with a resource to which you can find this measure. It's just a one-page measure, and I have a whole bunch of them in there for you, by the way, and where you can find them, etc. And that is in the public domain, so it's free to you. It is defined as a spiritual crisis during bereavement that compromises the griever's sense of a relationship to God and or the faith community, such that he or she struggles to reestablish spiritual equilibrium following the loss. With that said, I want to say this. In all research, especially this is relatively new, in all research, there's also a need for future research, limitations of the study. They are aware that they are focusing on the word God. Not everybody uses the term God for one's higher power. Okay. Just want to be sensitive to that. So what is, if traumatic loss is going to hit anything, it's going to hit religion and spirituality. All right. There's something called negative religious coping. And this is when a person's mood, that their mood states such as anxiety and depression, hostility, are related to their belief systems or their relationship to one's higher power, especially if they're starting to feel punished or abandoned. So they begin to attribute their feelings of that to one's higher power. Anytime you have a loss, it creates a crisis. And a traumatic loss creates a whole nother layer of crises. So they may have had this once perceived loving, all accepting, protective one's higher power, but now they may be feeling punished or abandoned by their client. Excuse me, abandoned, excuse me, not by the client, that'd be weird. Abandoned by their higher power, or maybe their higher power was controlling or authoritative. Well, what if you grew up in a family in which the attachment was very controlling or distance or authoritarian? And now your higher power, which was once found to be a resource for unconditional love, has now shifted into more painful dynamics of what happened with the trauma growing up. And now they're being re-traumatized. A client that I worked with, whose son died in a very traumatic way. And she was, as a child, extremely traumatized. She was out of the country at the time that he died. He was an adult. He died in a tragic accident. So there was a lot of intrusion going on for her. She also had a lot of belief systems that had she not gone on a lot of the if onlys or what ifs, if I had not gone, away, he would not have died. And that's, I wouldn't have expected differently. But it does kind of sometimes move into like a little bit of like magical thinking. It's not a judgment, it just, for lack of a better term. So we talked about how she believed her God gave her her son as a reward for having survived her abusive background. So that after she lost her son in such a traumatic way, where she was trying to fill in the pieces of what happened, like, was he calling for me when he was dying? Was he scared? Was God there with him? Because she's a very religious and spiritual person. She felt like she was being punished. And she goes, I don't understand what I have done that God would punish me so bad. I've already been through all this. He gave me my son as a gift. Oh, I can feel that in my chest and behind my eyes. This tightness of the absolute horror of her grief. And then the loss of her belief in her higher power, and then her spiritual community, who had a lot to say about the fact that he was not baptized, and so he was going to purgatory. And she couldn't find a balance. She couldn't integrate the belief system of how is he going to purgatory when he was this amazing human being? Why would God do that? So her religious community turned their back to her significantly. And that's part of when we talk about looking at religious and spirituality and complicated spiritual loss, it's one of the things that we measure is the reaction and connection to one's spiritual community. So she couldn't reconcile that her son would be in purgatory just because he was not baptized in her mind. So she begins to question his character, meaning the higher power's character. And there might be a desire to get back at that higher power. And then the ability to try to make sense of what's happened, on top of the fact that it's already more difficult with the trauma, intrusive, thoughts and memories and hypervigilance that comes with that. That then ends up leading itself to an existential crisis. And again, we're already in that crisis. So this then exacerbates that problem. In some cases with trauma, there are no prescribed rituals. What if there was an ending of a relationship, a long-term relationship in which there was abuse. Perhaps it was a lot of domestic violence, so there was like a chronic amount of trauma. You may hear people say, "Oh my God, it's so much better that you're no longer with him. You're so much safer." And while that might be true from an outsider's perspective, there's a disenfranchisement there, but there's also no ritual associated with that. So that spiritual anguish in ways that the person's life is devastated, and perhaps the changes in their spiritual beliefs, or the anger, confusion. And then they may have afterlife concerns like the client I just told you. Did my son go to purgatory? My religious belief system says he will go to purgatory because he was not baptized. And is he not going to heaven? And I have to work with her. I can't look at her and say, somebody that wonderful and loved by God would never allow him to go to purgatory. I'm not going to say that. I'm going to sit with her as a non-anxious presence and be that container. Your room's not just the container. Therapy's just not the container. You are also a container. And if you can't sit as a non-anxious presence when people have these traumatic and grief-related experiences, you may find it challenging to sit in that space. And then what happens? And then what happens to you? So afterlife concerns. And they may pull back from faith-related activities. They may feel betrayed and robbed. Their maybe spiritual community lied to them, or they felt abandoned. So they pull away. The stigma and disenfranchisement. God never does anything for no reason. He was an angel and God needed to have him with him. I mean, these are things that are said to try to help like the other person feel better, and all they want to do is slap the snot out of the person that said that to them, or question, should I be feeling this way? Am I betraying my God because I'm not thinking the same way? Am I being ostracized from my community? With that one client that I told you about where they were like, hey, he didn't go to heaven, he went to purgatory. She was actually, I just wanted to let you know there was something positive that did come from that work with her. One thing she did find was a religious community with the same from the same religious orientation, who brought her in and wrapped their arms around her and didn't say that to her. It was beautiful. It was beautiful to see it. So, the big thing about the impact of traumatic grief, the big topics, right? Here we go. Doesn't that picture just like, I don't know. I remember when I found this picture, and it's like, I don't know. It's intense. Okay. Look at that. Take a whole screen. We are not given permission to do this. Oh, I'm going to share something with you. All right. And it's medical trauma. It's something that just happened to me at there's a trauma conference yearly. Well, there's a lot, but there was this one trauma conference in Boston. I don't know if any of you were there, but I was. And Frank Anderson was there, who does a lot of work with internal family systems and a lot of work with, trauma, obviously. So I was sitting in the front of the room, and I did not realize there was about 900 people in the room. And he was talking about anger and how we tend to shut our clients down from anger for whatever reason. Maybe anger is uncomfortable for you, or the anger, like, they're allowed to express it to a certain degree, but afterwards we have to try to ground them and get them, all of that. Yes, we want the people to be able to self-regulate, down-regulate, all the things, but we want to allow the people that we work with and ourselves to be able to express our anger in a non-destructive way, right? So he had us all stand up, think about something that we felt angry about, and express it for about 10 seconds. So the first thing that popped up into my mind was all of the medical trauma that I experienced. And without going into all of it, let's just say there was a lot of it, and there continues to be a lot of it. And I remember screaming like most people in the room were, but then I started, crying, right? So I'm sitting there and I'm watching this guy's walking back and forth. I'm like getting EMDR from like how much he's walking back and forth. And at one point he goes, "You come here on the stage." And I'm like, "No, no." He's like, "No, no, come on up here." And I'm like, "Oh God, this is gonna happen." So I go up on stage and I pretend all those people aren't there. And I sit in front of them and we talk about my anger. We talk about what happened. We talk about what made me pissed to the highest of pistivity. And yes, that's a word. And after 40, you get to make up words. And that's one. Congratulations. And you're welcome. You're allowed to use it. I give it to you. After 50, you get to make up religions. I'm on my way on that one. Seriously. So pissed, festivity, there I'm at. And I'm sitting there and I'm talking about what happened. I didn't even, like, I knew I was upset about it. I knew I was sad about it. I knew I had some anger around it. But boy, my God, it really came out. And I'm like, all these people, fine. And at one point, I'm like, I'm crying. I'm like, I'm sorry. I'm sorry. And like 2 seconds later, I look at this entire room full of people who are therapists. And I went, I'm not sorry. I'm not sorry. I'm not sorry. I'm pissed. I'm pissed that this happened. What are you angry about that you're not talking about? What do you not share with people? Let's talk about the impact of traumatic grief. Let's go there. Thank you for letting me share. Not that you have a choice, but thank you for letting me share that with you. So how does trauma interfere with the grieving process? This picture freaks me out, but it's exactly what just, it almost personifies how big traumatic grief is. That intrusions that we've been talking about, that loss is relived over and over again. It's not remembered. The death scene, what happened, actually ends up replacing the relationship. It is an overriding response. Think about that. They cannot connect because the way the person died is being relived over and over again. There's the avoidance. Somebody has to avoid avoidance. That relationship cannot even be accessed. If I go there, I am going to, if I don't go there, I don't fall apart. But then I can't grieve. The avoidance, we're what is it? Fight, flight, freeze, or fawn, right? Trauma impacts our system. You might as well be getting chased by a saber-toothed tiger. Your body doesn't know if your body's being chased by a saber-toothed tiger versus, the fact that you know that your child was hit by a car and killed on impact while he was in the crosswalk of his school. So how do you respond? Avoidance isn't always a negative thing. We have got to normalize the way that people experience their trauma and normalize how people navigate their traumatic response, and then help them gently find a way to approach navigating the traumatic response so that they can unveil the grief response. One thing that's really problematic is we have therapists who will assess for trauma or assess for grief, but won't assess for both at the same time. In traumatic grief, you have to do both at the same time. But that avoidance, I want to be able to say to you, yeah, that avoidance was brilliant. Are we at a place where you're willing to step a toe in and go there? But I better have a good relationship with you. We all talk about rapport, of course. And I don't know how many of you are in positions where you're able to have enough time to develop a good, strong amount of rapport. But if you have that space to do that, then opening up that avoidance, because they're there to try to process it, right? We don't want the avoidance to stay there. We're just going to perpetuate the cycle. They have to be really grounded with you. That dysregulation on a physiological level, their system is too activated or too shut down to actually process. So that trauma on a physiological level interferes with that grieving process. Their bodies can't handle it. Not yet. And then their ability to make meaning, the integration that we talked about earlier today, nothing fits anymore. The whole flipping world shattered. So how can integration happen? They can't even get out of their own space yet. Yet. You're here to find out yet. So what happens to grief when trauma is present? Well, the person's memory can become fragmented. That bond can become, contaminated and therefore unable to be accessed. Our nervous system gets out of the way. I don't know how many of you, again, are familiar with some of the basics. This is like basic neuropsychology. I understand it's way, way more complicated than that. We don't have time for this. But if your limbic system and your amygdala, as part of your limbic system, is on fire, your survival part of your brain is on fire, your executive functioning is offline. That's the part of your brain that thinks about things, that is able to, you need to be able to experience feelings and experience thoughts at the same time. And when you can do that, you are inside what is called the affective window. If you are hypervigilant because your anxiety is so high, because you are so activated, you are outside of your affective window, and getting your executive functioning back online is not going to happen yet. If you're hypovigilant because you're completely shut down, it's the same problem. The body isn't regulated. It is not at a place where it is able to think and feel at the same time. So until you can get a person to be in a place where they can think and feel, you're not going to be able to do this work effectively. Or if they can go into those places and have the coping skills to bring themselves back down, because it's not going to be a linear experience. So the access to their grief ends up becoming restricted. And then the meaning making stalls, and there's not the integration that needs to happen, and it's going around and around. So when we talk about the nervous system and the grief processing, there are safety is needed for processing. So you can't go anywhere until the person has the ability to have the foundational ability to, I just repeated myself, whatever, navigate it. That person's got to be able to sit with their grief on a physiological level. But trauma narrows that window. When we are traumatized, we are built from ancient, old times to focus in on our traumas, to focus in on our threats. Again, your brain doesn't know the difference, not that old part of your brain. We are meant to focus. Again, if I have a saber-toothed tiger, that could kill me and be traumatic for all the reasons. I need to focus, right? I can't be over here picking out strawberries and also be aware of there's a saber-toothed tiger. Well, when we have trauma in our grief, we do the same thing. We narrow in. We relive the memory, the intrusive memories. So one way when you're working with somebody, when they're ready, is to help them learn how to open up that window. And there's actually somatic ways of being able to do that. I wish I had more time to jump into that, but things like being able to move your head a little bit, just slowly moving your head, looking out at an imagined horizon, just getting out of that trauma-focused mindset. And then surviving if we can get a person to survive that on a physiological level, we then can move into more of the meaning. So all of that then leads us to talk about prolonged grief disorder. Again, I'm not going to tell you how to treat prolonged grief disorder. There are a lot of places that you can go to learn how to treat it. It is a specialty. Grief in and upon itself is a specialty, but you can do grief counseling and not have to have a specialization. But when it comes to prolonged grief disorder, this is a combination of both trauma and grief intersecting, where almost the grieving process itself can become traumatizing. So let's talk about this. This is when grief goes awry. Remember this picture from the beginning of today? Yeah? Well, this is what happens with prolonged grief. Nope. This is intense grief that does not go away. Intense separation anxiety. intense ruminations, maladaptive thoughts. I'll give you some examples. Maladaptive thoughts, dysfunctional behaviors. It's as if the acute grief does not go away. I have had clients that have come in. I had one person I'm thinking about, gosh, this must have been 15 years ago, if not more. And she came into my office. I had been told that she had her mother had passed. I mean, she was completely outside of her affective window. So, a little bit of slowing down there, but like the that kind of crying. And I was like, my God, this must have just happened. That was my assumption, that this must have just happened. And then, we talked a little bit more, and I was like, how long ago was this? 10 years. Okay. I'm not going to assume, longer than, I'm not going to assume, that 10 years means anything yet. I need more information. So I'm going to step back. I have a differential diagnosis going on in my brain, but 15 years ago, there was not prolonged grief disorder. Don't get me started about grief in the DSM and all the things, because that'll be a whole nother soapbox and you'll be like, oh my God, we're not on track. But prolonged grief disorder, I was like, something's up. So as we're talking every week for a few weeks, I'm realizing this person had a very enmeshed relationship with her mother. And when you have a very enmeshed relationship with person, that makes it even more challenging to navigate the grieving process, because that person became completely part of everything in your life. So the separation, because there was a fear of the ability to be independent, because there's intradependency and interdependency, like in secure attachment, there's both. Because it was so enmeshed and there was not a secure attachment, when she was gone, the assumptive world just shattered and crashed. And she would spend hours in a closet. Now, I have no issues where there being an area in the home that's kind of like a shrine. If you could see it, I've got one over there. I've got my parents. It's actually quite healthy. Her home was a museum. Nothing changed. Everything around her for 10 years, anything her mother had touched for the last time was not moved. That is a museum that is being completely surrounded by the reminders that the person has passed away. How do you accept the reality of the loss when even your physical environment hasn't changed? And I'm not saying a month after. I remember my mom during that week between my dad dying and her dying, she was going through his clothes trying to figure out what to do with them. And I went to her and I was like, slow down. You don't have to figure this out right now. But I think her life was so shattered at that point, she just didn't know what to do with herself. But the museum part, it is a problem. And after 10 years, definitely a problem. I'm not saying don't have a dedicated place. Please, by all means, I think it's a beautiful thing to do. So her acute grief was not ending. And we did a lot of work. I can't go into all the work that we did. We did a lot of work around her being able to figure out how to stabilize herself, because you just don't go into all this unless the person is actually able to be braced. If the person doesn't have bracing skills, then you've got yourself an issue. You cannot open up anything, obviously, until the bracing skills are in place, right? So even though it's there, you might have to kind of be the one that is navigating how fast the deluge of the reactions to the trauma and the grief are coming down, so that you can dose it. I have a client I was working with, lots of trauma. This is just recently. And we were going to do a case study about her, but lots of trauma that has occurred. And she was just going like through one to the other to another. Now, I already had a rapport with her that had built up really well, but she had decided she wanted to go down this route in therapy. And she was going, well, then this happened, and then this, and this, and this, and this, and this. And I stopped her and I said, I'll call her Lisa, because we're going to talk about her later. Lisa, I said, can I stop you for just a second? She said, yeah. I said, we don't have to rush our way through this. I'm wondering what's happening for you right now. what's happening as you're going through, just listing these and saying very quickly how it was upsetting and then moving on. I do not like asking why questions. What, how, help me understand a little bit more. You get so much more information, I promise. Anyway, so help me understand what's happening right now, Lisa. Well, she goes, well, there's just so much, and I just don't know how to handle it all. I'm like, you know what, then? We can dose this out. Let's go slower. How about, would you like to start at the beginning, or would you like to start at maybe something, another place? I'm going to give her, I don't want to be the one that says, you've got to start at the stop, or, there. What if there's something bigger that she wants to start with? So where would you like to start? But let's slow down a little bit. And so much work happened to the point where at some point she knew she was going through and she goes, I'm not dosing. And I'm like, okay, I'm glad that you got words for it. Okay. So another video, it's of me this time, but this will give you some more information.
Welcome to Phoenix Rising with Dr. Z. This podcast is all about conversations about healing and rising from the ashes of your grief and trauma. In this podcast, we will be deconstructing and highlighting the different aspects of grief and loss. I'm your host, Dr. Christina Zampatella. Okay, we are going to talk about prolonged grief disorder. What the hell is prolonged grief disorder? We're going to find out about what prolonged grief disorder is. I'm going to give you a little bit of history. I'm not going to belabor it, but I think it is important for you to understand that in the research in the field of thanatology, which is death, loss, dying, and grief, all right, in our field, there has been, and there always will be, without a doubt, significant debate on whether or not there is a disorder that can result as in reaction to a loss that seems to be stuck, that grieving process. The definition of stuck, I'm going to tell you a little bit about the definition, but I want to tell you a little bit more about where we're coming from. So starting in about the 1980s, 1990s, it became a lot more popular for researchers to evaluate and explore this experience that they're noticing with some people who seemed to not be able to move forward in their grieving process. Now, a lot of argument about, well, how much time should it take? If I knew how much time is a normal grieving process, I would not be having this podcast right now. I would be in the Caribbean, hanging out on my yacht, and I'd have it all figured out. I do not have it all figured out. I do know that we have some guidelines now, but they're guidelines. And again, I'm going to come back to that. I keep saying I'm going to come back to that. That way you keep listening. So either way, trying to figure out where I'm going with everything. So what was happening is that some percentage of people who have lost somebody, and at any given time, about 60% of people are bereft, are in the active process of grieving. That is a huge amount of people. We have 330 million people just in the United States. And this is found cross-culturally. This isn't just something found here in the United States. About 10 to 15%, and that depends on the researcher. Some say 7 to 10, some say 10 to 20. I'm going to say 10 to 15 with the understanding that I'm just kind of, breaking the middle there. About 10 to 15% of people who are bereaved have what we would call prolonged grief disorder, the way we would define it now. Again, there are some people that say there is no prolonged grief disorder. There's just grief, and sometimes grief gets stuck. Then there are other people that are saying, no, there's prolonged grief disorder for sure. And we're going to go ahead and stick it in the manual that mental health professionals use in order to, quote unquote, diagnose somebody. And then other people get angry at that because now it's like, oh, okay, well, pharmaceutical companies are going to try to medicate this disorder. And you're right about that. In my opinion, I do think that they are going to try to do that. And I'm allowed to say that on my own podcast, but I have to be careful in other places. But I'm going to be careful here. All right. So prolonged grief disorder. So it was confusing because there was, before, earlier in the 2000s, there was a belief that you could not diagnose major depressive disorder if it was within 2 months following the loss of a person. It was called an exclusion criteria. All right, neither here nor there. What they were trying to say is you can't assume somebody is depressed when they're bereft. And apparently you get a 2-month period of time. Problem was, from some researchers, they were saying, wait a minute, you are potentially overlooking people who actually do have major depressive disorder and are grieving. So there's that group of people. There's this other group of people that are saying, no, you don't want to pathologize somebody who's grieving and turn around and say that they've got major depressive disorder. Grief is not a mental health disorder. We are all going to grieve. It is a process that naturally and organically unfolds. That process, again, naturally and organically unfolds in a very painful and difficult way sometimes for about 85 to 90% of people. Okay, what about this other 10 to 15%? When I say people are stuck, and there's been different words for it, complicated grief, traumatic grief, prolonged grief, persistent complex bereavement disorder, that was another one that was flying around. Right now, what's out there is prolonged grief disorder. These are individuals who have not had the ability to adapt to a loss. And for a long time there, like I said, it was there a major depressive disorder. You can't diagnose it. Okay, well, we're not going to, diagnose major depressive disorder. Maybe we're overlooking people. What if they're suicidal? Now we've got a big issue. What if we're overlooking that? There's a lot of what ifs, never clear. What is clear, though, is I have worked with people who 30 years after a loss, they are sitting in my office and you would have thought that the loss happened last week. The intensity was that high. They're not functioning. They're not re-engaging in life. They feel like part of themselves have died and they have not been able to restructure their identity. They feel like life is meaningless and very unfair, that they're maybe even emotionally numb. So 30 years later, if there's no adaptation to a loss, if we've not been able to make sense of it, if we've not been able to weave it in and then re-engage in the goals that we have in our lives, and if we're still avoiding things that are reminding us of that loss, like perhaps the person died and it was at this house over here, you totally avoid going over to that house or even driving by. By the house or even driving by the neighborhood. And here's the other thing. Some of this is understood. If I lose my child, part of me is going to feel like part of me has died. That would be a natural reaction. But that one reaction does not mean somebody has prolonged grief disorder. All right. So now the way that things stand is there's something called the DSM. I mentioned it earlier. The DSM is the Diagnostic and Statistical Manual that is used for mental health professionals to identify and define, and I just mentioned this, identify and define mental health disorders. It's meant there to be a guide. It is not meant to be like, okay, boom, person fits in this category and that's what they have. When you have a clinician who's pretty savvy, they have the ability to look at that and determine whether or not, does that really fit? Okay, yeah, they can fit into all those criteria, but there's all these other circumstances. Or this person was, as they were growing up, was abused throughout their lives. We call that complex PTSD, post-traumatic stress disorder. Complex PTSD. Does that mean, those symptoms that you see, I know I'm getting off subject, but I think it's important to hear. Does that mean that chronic PTSD can't look like another disorder and then that person gets misdiagnosed and now we're over here giving medications for something that they don't even have? Can that happen? Absolutely. Does it happen? Yep, sure does. So having somebody with enough experience with grief and trauma can, definitely help make sure that we're on the right path and we're working towards treating the right thing. So I think we need to be clear about how we're looking at what prolonged grief disorder is now. And the way that we have it now is that they're saying it has to be, and when I say they, it's like this group of people who were on this committee when they were putting together the new DSM, which just came out in March of 2022. If they have their timeline of 1 year. So the loss had to have been at least 1 year. For children and adolescents, it's 6 months. How did they come up with the year time frame? That's a great question. If you go into the literature, you can see people are all arguing with each other. And you'll see that they're saying, well, we don't want to pathologize people who are still really active in their grieving process throughout that year. But other researchers are saying, but wait a minute, hold on a second. I can see that through 6, 7 months, if that person, if there's no movement at all, the prediction, there's a likelihood that at 12 months, they're not going to get any better. So we've got two sides of the coin, and they're arguing with each other, and they're always going to continue to argue with one another. As a thanatologist, as a grief specialist, if I have somebody come into my room and they have lost a very good friend, that's one thing. If they've lost their child or their spouse, am I going to say, oh, 12 months, you should be really on your feet now? No, I'm not. I've seen people who have lost children and lost spouses, and it's taken years to get to a place. But I'm looking for things. I'm looking for shifting. Are you re-engaging in your life? So they say 12 months, 6 months for kids and adolescents. Now, one of the two have to be present. This like intense yearning and longing. It's almost like this massive separation anxiety that doesn't seem to ever reduce. No matter what you do, it's just this intense yearning and longing. Or you're really preoccupied with the person, the lost person, or the circumstances of the death. So one or two of those has to be present. And then, just like every other mental health disorder, there's a whole bunch of different criteria. And you have a list of 8 criteria, and you have to meet at least 3 of these. And they have to occur daily, and they have to occur to a significant degree. So examples of this, I've mentioned to you: marked disability of the death, the emotional numbness, feeling like part of yourself has died. You might have feeling that life is meaningless, feeling like this intense rumination, thinking about it over and over and over and over again, reintegrating into your life, like engaging in new activities and new relationships, new life goals, being able to engage in a life that exists without that person. Now, this, just so you know, prolonged grief disorder has to be due to the death of a person. In another podcast, I talked about non-death related losses. Nope, doesn't apply. This only applies to the death of a person, which is another area of contention for a group, for a whole big group of thanatologists and researchers in this field. So there's some argument about that. The fact that it's even in the DSM, that's been like a huge win for thanatologists. Before this version of the DSM, there was something called persistent complex bereavement disorder, and that was placed in the part of the DSM that you couldn't diagnose it. It was there for future research. All right, fine. We did a lot of future research. We finally got it into the DSM. In my personal opinion, and let me just point this out, an avoidance of the reminders. I talked about that. That's huge, because if I'm working with you as a clinician, one of the things that I'm going to talk about is how do we reduce the amount of avoidance that you engage in. That's actually part of a treatment for somebody who is dealing with marked disbelief about the death and so forth. Now, this disorder, there can't be another disorder that better explains this disorder. But what's really important to understand is that this has significantly different criteria that is separate from any other disorder. And I'm not just talking about like the symptoms that you see. I'm talking about like physiologically. People with prolonged grief disorder, their heart rates are lower. That there's issues with being able to, like, there's cognitive processing, thinking processes that are different. Being able to solve problems is challenging. That rumination, and what I mean by rumination is like going over it and over it and over it again, that actually keeps that loss in like your working memory. Your working memory is like if I said, okay, I want you to remember this phone number. And if you're like me, you'll remember 3 numbers and then you'll have to tell me what the number is again. I'll get to 5. Eventually I'll get to 7. And, calling the pizza place is already too late. But it goes around and around in your working memory. Can't stop thinking about it. All right. Because of that, it doesn't eventually get into your long-term memory. Because when you think about something over and over and over again, you're not allowing your brain to release the attachment to what you're thinking about enough to engage in the rest of your life so it becomes part of your autobiographical memory. It never integrates. So instead of it going from like this acute grieving process that often had that intense sorrow, the intense pain, the intense like physical symptoms, these interpersonal difficulties you might have after a loss, the spiritual difficulties you might be having,